Hello, I'm Mike Silver. I'm the Corporate Vice President of Improvement Science at HealthInsight. I want to thank you for the opportunity to talk with you today. And I also want to thank you for your hard work caring for the people who come to you. People like you, professionals like you, have made an important difference in the lives of people I care very much about. I appreciate it and want to take a moment to thank you. I'm going to start sharing my screen. This will just take a moment. Some ideas that I want to talk over with you today about what we'll call systemic safety. I have to move for residents and staff. I'm combining those ideas. We're talking about safety outcomes for both the residents and the workers. What we'll do is an overview of a snapshot of what we'll call systemic safety in nursing homes, and offer some ideas for your consideration, ideas on behavior-based safety. Objectives. So just a broad review of performance outcomes for skilled nursing facilities. We want to introduce some safety management principles and methods used in leading industries and consider applications, potential applications for your facility. When we look at quality and safety outcomes in nursing homes, the types of things we talk about include things like this: infections, falls, antipsychotic use, restraints, pressure ulcers, mobility, readmissions, emergency department transfers. When some of these would be considered to be healthcare associated conditions, not all of them, not all hospitalizations, readmissions, that sort of thing are preventable. These are not the only outcomes we want to talk about today. We also want to talk about worker safety. I think that most people that are in the meeting today are familiar with this, that nursing homes have one of the highest rates of injuries and illness among industries that have to report on this sort of thing. In the Bureau of Labor Statistics, nursing and personal care facilities experience a lost workday injury and illness rate of 4.9 compared to 1.8 for industry as a whole, despite the fact, at least in the assessment of OSHA, that feasible controls are available to address hazards within this industry. You can see that nursing aides and orderlies have a very high rate, the highest rate of musculoskeletal disorders of all occupations, almost 250 per 10,000 workers, compared to an average rate across all industries of 34. It's not the only outcome we wanted to introduce today. We also want to talk about clinician burnout. This has been described as a potential public health crisis. Burnout is recognized, widely recognized, that burnout is common among all healthcare workers. Until recently, the prevalence for nurses was estimated from 10 to 70%, pretty wide range. But every time I see statistics on this, I see it growing. And 30 to 50% of physicians, nurse practitioners, and physician assistants. What is the impact of this? Well, the impact is direct. Burnout is not an outcome that we want to produce with any workplace. But more than that, of course, burnout, at least it's postulated, it's speculated that emotionally exhausted clinicians restrict or curtail their performance to focus on only the most necessary tasks. They don't, if you will, they don't tend to go that extra step. People with burnout, clinicians with burnout are thought to have impaired attention, memory, and executive function that decrease their recall and attention to detail. Not a good situation, not a situation we're seeking to produce. Now we've seen improvement in quality and safety outcomes in nursing homes across the country over the last 10 years or so. And at the same time, we're seeing more burnout among clinicians across various healthcare settings. Well, we wanted to ask the question, or at least review, is it possible that burnout is increasing even as quality and safety measures are improving? Might those things be connected? There's some reason to think that there might be. And the reasons come from a discipline or field called systems thinking. And some principles that, or some lessons from from systems thinking that point us in that direction include these. That there's a risk that some of our efforts focus on symptoms rather than root causes of quality and safety problems in nursing homes. And when we do that, when we focus on symptoms rather than root causes, we will tend to produce earlier, more rapid improvement in measured outcomes. That is the thing that we target. We tend to get better results earlier on if we focus on symptoms. However, that comes at a cost. Those same efforts tend to stress rather than reform the existing processes and systems. They tend to decrease staff satisfaction and increase burnout. At the same time, if the focus of our activities focus on symptoms rather than root causes, we can expect to increase cynicism, reduce voluntary interest in participating in improvement activities, inhibit our trust and respect for management and change agents. And it's likely that performance on the things that we don't target is eroded. So if these principles have application or matter in our field, in nursing homes, then one of the things we ought to be reviewing as we approach improvement efforts is that anytime we have identified a performance gap, any healthcare associated condition, anything that we target, we should be asking ourselves, is it possible that this thing that we've identified is not the real problem, but that it's a symptom of a deeper problem, a symptom of a deeper problem that should be the focus of our efforts. Okay. If this is finding some relevance to you, if you're saying yes, these things might be connected, these might be outcomes that we need to take a deeper look at. We have some ideas. We've brought forward some ideas from industrial and occupational safety that may provide additional insights. So that's what we're going to review now. Something system safety approach around behaviors and staff engagement. Okay, so there are some, to motivate this, we'll review some principles. That is, and we'll begin with this, that are risks for healthcare associated conditions, are risks for negative resident experience, a risk for worker injuries, for burnout. All of those can be mapped back to specific tasks and within tasks, critical behaviors. Any particular task that staff is involved with may have implications for multiple hacks or multiple types of worker injuries. The design of tasks and the reliable performance critical behaviors and prospective risk management all benefit from direct engagement of unit staff. This is a lesson that we've extracted from study of industrial and occupational safety. Moreover, safety culture, satisfaction, and organizational citizenship behaviors are all enhanced through unit-based staff or frontline staff engagement activities. So again, reminder, we look at the way we might characterize quality and safety targets in nursing homes, a number of different types of hacks, infections, falls, mobility, those sorts of things, readmissions, EDs. That's one way to characterize things. We look at worker harms, and for example, if we look at the harms that nursing aides, orderlies, and attendants are exposed to. We can see the different types of expression of harm that they may be subject to. This diagram asks us to consider those sorts of things in a different manner. We'll start with the right-hand side of the graph, where we have undesired results of the design and conduct of tasks and critical behaviors. And in there we see our hacks, other forms of negative resident experience, worker injuries, and worker experience or burnout. And this graphic, what we're trying to communicate here is all those outcomes can be traced back to the same sorts of root causes, if you will. The design and conduct of the tasks and critical behaviors determine what types of results we see in our system. This graphic also proposes some methods for managing that root cause, the design and conduct of tasks and critical behaviors. It proposes, one, we take a prospective risk management approach, that we look at the activities that we do and seek to understand the risks and use that information to inform or to manage the design and conduct of our tasks and critical behaviors. It actually proposes one more idea here under the second on the left-hand side where it says behavior-based safety. What this does is outline a process for staff engagement. We engage teams in active and continuous improvement around the design of tasks and critical behaviors. We do this in a specific way. These engaged teams, these frontline teams, define, use their knowledge of, or seek to understand the sources of risks, and based on that, define the critical tasks and behaviors in their work environment, gather data on the performance of those tasks and behaviors through observation, provide feedback, and use accumulated data to identify, prioritize, and solve problems. So if we're talking about the difference between symptoms and root causes, what this graphic proposes is that the root cause of the types of things that we see here on the right-hand side has to do with the way we engage staff in prospective risk management. That's the proposition here, is that it really comes down to that experience really comes down to the quality and effectiveness of our staff engagement efforts. Now, options for putting this into practice. There is growing expectation, explicit expectation for quality assurance and performance improvement activities in nursing homes that engage frontline staff. So this is something that you'll be pursuing in any case. What I'd offer, or maybe already pursuing, what I'd offer is that this requirement around QAPI is it may feel like this is one more demand, one more problem that you have to solve. I'd like to propose that this is actually good news, that this isn't another problem to solve, this is a solution. This is how we're going to get to reduced healthcare associated conditions, improved worker injury or reduce worker injuries, reduce worker burnout, that sort of thing. We're going to get there, at least it's possible to get there through exactly this sort of process. When we do that, when we engage frontline teams or a frontline team in improvement efforts, it will help us if we shift our approach away from taking a hack at a time, different types of hacks, one at a time. Moving away from that, instead of looking at those hacks, move upstream and look at the sources of risk, look at the sources of resilience associated with specific tasks and activities. You may have, as I mentioned, some facilities may already be partway or most of the way there, at least with some of the raw materials. You may have participatory safety and improvement teams already. Those teams may have some quality and safety skills, maybe even sophisticated skills. We'll have an opportunity to build upon this base. We can broaden their agenda to include worker safety, staff experience, and burnout. And as we were establishing this prospective risk management capacity involving our frontline staff, we can help them develop new skills in safety and quality management. Things like, and we'll review these in later sessions, things like something called applied behavior analysis, helping them become more effective in task design, the application of human factors, resiliency to prevent burnout, and something called just culture. The process is, on an ongoing basis, a team like this would identify 2 to 3 critical tasks that really make a difference in terms of the resident experience, in terms of the potential for hacks, in terms of the potential for worker injury. Identify 2 or 3 of those critical tasks, define them, collect data through observation, provide feedback, and use the information or the data gathered to further reduce risk, and then continuously do that. So a little while ago, I mentioned that there's a problem of burnout in healthcare workers and clinicians, and this is a problem because I've outlined a process for engaging frontline staff in improvement activities, and yet at the same time we said those same people are very likely to be burned out, and that's a problem because it's hard when somebody's emotionally exhausted to ask them to do more to contribute to the well-being of the organization and of residents. So there's a couple things. We can deal with this. We'll introduce some resiliency tools, activities to prevent or reduce burnout among your staff in future sessions. I also want to point you to a resource that's available right now to you. Some colleagues from the Duke Patient Safety Center have a program, it's called the 3 Good Things activity, and they sign up cohorts throughout the year, and people can participate in this, and it's a direct way to start reducing burnout. Again, we'll come back to this in future sessions. Summary. So we talk about a culture of safety in, well, not just nursing homes and hospitals and other healthcare settings. And what we're proposing is that the idea of a culture of safety rings a little hollow if that doesn't incorporate worker safety as well, or other negative experiences that can happen in the workforce. So we're proposing that we start combining those ideas, that safety is overarching and includes both resident and worker safety. That the other thing is that to push us to even greater levels of safety performance for residents and for staff, we might have to look at new approaches. And the good news is that there are promising approaches that have been demonstrated in other industries. These staff engagement methods and behavior-based safety are evidence-based with broad experience, again, in many industrial settings. We mentioned the idea of resiliency. Again, we'll return to that in future sessions. And we want to let you know that HealthInsight can offer resources and technical assistance in all these areas. So now it's your turn. We want to hear from you. We've introduced a lot of ideas in a broad way. We want to get a sense of, is this something that you're interested in? Something that you might be interested in pursuing, something you're already pursuing, and want to find ways to do it even better. Questions that you have, reservations. So we're going to talk as a group about that, and I hope to talk to you again in the later sessions. Thank you very much.